Bismillahir Rahmanir Rahim. Our case today very interesting. Late preterm 36 weeks, symmetrical IUGR, low birth weight 2 kg, infant of diabetic mother, and admitted to NICU due to severe RDS and received 1 dose of surfactant and connected to mechanical ventilations and nursing staff calling Dr. Reham, please can you come to assess the baby or to see this child. Why? Because the baby was desaturated up to 80% and there is pink red fluid secretion in the ATT and oropharynx, indicate pulmonary hemorrhage, and also having a baby low Apgar score from the start. Dr. Reham, she came, assessed the baby clinically. There is by auscultation, there is widespread crepitation in the back and looking for the monitor there is tachycardia, and also there is some element of congestive heart failure, tachypnea, tachycardia, and the tender liver, indicate significant PDA and machinery murmur also with winding pulse pressure. So the assessment at that time, this is late preterm 36 weeks, low birth weight 2 kg, symmetrical IUGR, pulmonary hemorrhage, early onset mental sepsis, infant of diabetic mother, and because low Apgar score there is element of hypoxic ischemic encephalopathy. So she is looking for what? For the risk factor for pulmonary hemorrhage. Yes, the baby risk factor, preterm, RDS, and PDA, hypervolemia, especially in the first 24 hours, and coagulopathy, sepsis, IUGR, hypoxic ischemic encephalopathy. This is all risk factor for pulmonary hemorrhage. Dr. Reham, she started to request for what? First, initially blood gas, looking for or checking for oxygenation and the CO2, and requested for chest X-ray. There is classic white out lung and with air bronchogram and resembling RDS. For sure, she requested for septic workup and started antibiotic because the sepsis one of the risk factor for pulmonary hemorrhage. FBC or CBC, looking for anemia, might be need to correct it. Clotting factor, coagulation profile, need to fix, and you can request for blood product. And she requested for echo to confirm or to check if there is any significant PDA might be the cause for pulmonary hemorrhage, and she requested for ultrasound because association with intraventricular hemorrhage or intracranial hemorrhage. Dr. Reham started to treat the baby. What is the bedside management? The first thing Dr. Reham, she do it, she called the consultant and the senior. Why she called the consultant and senior? First, because this is emergency condition, life-threatening condition. The second, may the baby deteriorate rapidly or lose the baby. The third, give a chance to your senior to come if he's outside the hospital. Then started to do the ABC, airway, breathing, circulation. And the A, the airway, you have to mention 3 no. Don't handle the baby too much. So you have to sedate the baby. The second, don't remove the ATT. Why? Because severe active bleeding may not able to insert another one because you cannot visualize the field. The third, no suction. Avoid unnecessary suction unless there is evidence of airway obstruction or secretion or clot blocking the airway. B, breathing, ventilation point of view. Patient on conventional mechanical ventilation, so you have to increase the beep from 6 to 8 or 8 to 10 centimeter water. Why to increase the beep? Just only to compress the capillary vessel to stop the bleeding, and also you can increase the inspiratory time to 0.5 seconds. And if the baby on the conventional mechanical ventilation, you can shift him to high frequency. Why high frequency in pulmonary hemorrhage? Just to splinting the alveoli and compressing the bleeding vessel. But what about surfactant therapy? As we know, surfactant can increase risk of pulmonary hemorrhage. Why? Because decreasing intrapulmonary pressure leading to left to right shunt and open the PDA and increasing the pulmonary blood flow. So once the pulmonary hemorrhage it's happening, you have to treat with surfactant therapy, especially in cases of secondary RDS, as we know the blood leading to denaturing of the surfactant, so you need surfactant therapy. If there is metabolic acidosis, you can use it sodium bicarb if indicated or needed. C. Circulation, fluid management, and inotropes. There is 3 scenarios: evidence of hypovolemia or evidence of hypervolemia due to volume overload from fluid in the first 24 hours, or BDA. If there is evidence of hypovolemia, so you have to give slow pulses of saline or blood, and the blood is preferred because there is hemorrhage, and you can think about what? Inotropes. If there is no hypovolemia and there is evidence of volume overload, congestive heart failure, so you have to give furosemide or Lasix, because the basic pathology, it's hemorrhagic pulmonary edema. The third scenario, if there is BDA, you have to restrict the fluid to 60 ml per kg per day. D. Drugs or blood products. If there is evidence of anemia, you have to give blood transfusion. If there is evidence of coagulopathy or prolonged coagulation profile, you have to give fresh frozen plasma. And if there is evidence or suspicion of hemorrhagic disease of the newborn, you have to give vitamin K, or there is liver derangement. And put in your mind, you can give factor 7. Why factor 7? If the bleeding is not stopped and there is suspicion of factor deficiencies. And also if there is evidence of sepsis, because sepsis, this is leading cause of pulmonary hemorrhage, you can take septic workup and start an antibiotic, and can review the culture after 48 hours and the condition of the baby. In summary, الزبدة الزيتونة, what is the bedside management of pulmonary hemorrhage? A. First, you have to inform your consultant or senior immediately. Why? Because maybe the baby deteriorates rapidly. And A, B, C. A. 3. No. Don't handle the baby too much, and you have to sedate the baby. Don't remove the ADT. Why? Because severe bleeding may not able to insert another one. No suction. Avoid unnecessary suction unless there is airway obstruction. B. Breathing. This is a baby on conventional mechanical ventilation. You have to increase the beep from 6 to 8 centimeter water just to compress the vessels or the capillary vessels to stop the bleeding, and increase inspiratory time to 0.5 seconds. And shift the baby from conventional to high frequency. Why? To splinting the alveoli and compressing the bleeding vessels. Surfactant therapy. Surfactant therapy in cases of secondary RDS, and actually surfactant therapy, it's the blood denaturing the surfactant, so you have to give surfactant replacement therapy. If there is evidence of metabolic acidosis, you can use sodium bicarb if indicated. C. Fluid management depend on the condition. If there is hypovolemia, you have to give bolus of the saline or blood, and the blood is preferred, and you have to think about inotropes. If there is hypervolemia or evidence of congestive heart failure, you have to give furosemide. If there is significant BDA, you have to restrict the fluid to 60 ml per kg per day. Drugs or blood product. If there is anemia, you have to give blood transfusion. Coagulopathy, you have to give fresh frozen plasma. If there is liver derangement of a suspicion of hemorrhagic disease of the newborn, you have to give vitamin K and factor 7 if there be resistant bleeding and there is suspicion of factor deficiency. And you have, if there is evidence of sepsis, you have to take septic workup and start antibiotic and review the culture after 48 hours or the baby condition. شكرا. سلام عليكم.